It's a huge privilege to be here in this lecture theatre today, and you know, as we sit here looking around us at these beautiful quotes in French round about us and just appreciating our environment, I wanted to talk to you a little bit about connection, or to start off by talking to you about connection. And maybe you could just close your eyes for a little second. Let's just have a little peaceful moment. And I want you just to think about someone, or a pet, or a place that you feel connected to. When I think about people that I feel connected to, or a place that's special to me, it's immediately calming. It's immediately something which reaches me, which makes me feel joyful inside. Connection is a powerful human emotion that we need, and it's overlooked. And the society that we live in these days sometimes means that it's more difficult to establish meaningful connections. That sometimes we're so hurried that we don't appreciate the connections that lie around us. And sometimes there's insidious forces that exist round about us that try to reduce the nature of those connections, to belittle them. And we've got to resist that. We are humans. We're not rats. We do not live in a rat race. And we must ensure that that most basic of human emotions, connection, is something that we nourish and protect. The Chief Medical Officer position is a fascinating role. It's such a wonderful privilege to be able to do that for Scotland. And I want to start off by just saying a little bit about it, because that puts into context what we're about to talk about. So, first of all, it's 3 different jobs. The Chief Medical Officer component is an independent clinical and public health advisory role that in itself is a sub-office of the Scottish Administration. So it actually sits separate from Scottish Government. And that's really, really important because it preserves my independence. The second part of the role is as a professional lead for the medical profession in Scotland, what we call NHS Scotland, although there's no real legal entity of NHS Scotland, but I am the higher level responsible officer for Scottish doctors. And then the third element is as a policy director in Scottish Government, and that's the bit that attaches me through to Scottish ministers. So 3 different elements, but that first element, that independent clinical advisor, for me is the most important of them all. And what it has allowed myself and my predecessor to be able to do is to develop this concept of realistic medicine that we heard Rod talk about, and that we'll go on and talk about a little bit further in this. One of the things I get to do as the Chief Medical Officer is each year to produce my annual report. And that's really where the concept of realistic medicine started. My latest one, there's a QR code there you can use to kind of that will take you to it. But these annual reports are a commentary on the health of Scotland, but also on where I would like to see practice develop. And it becomes an incredibly powerful tool to be able to speak not just to the profession, but to healthcare more widely, and also to the population of Scotland. And that's how we've used it over several years now. So let me start by just saying a little about where I think the biggest challenges that we face currently are. The 4 key population health challenges. I am quite sure that these are not unique to Scotland. In fact, I know that they're not unique to Scotland, and you may identify with some of them yourself. So the first of those challenges is the ongoing threat posed by the spread of infectious disease of one sort or another. Not just novel agents such as we saw with COVID-19, but actually some of the more traditional forms of infectious disease as well that still cause problems all across the globe, and certainly nationally within Scotland. But there's a threat that sits behind that as well, which we need to pay more attention to, and that's of the rising spectre of antimicrobial resistance and changing attitudes across many countries with vaccination as well. Vaccination is a gift from science, and we need to make sure that we protect that gift and that we make it the most simple, easy and straightforward choice for anyone who's offered the vaccination to be able to take it easily. The second population health challenge is that of improving both healthy life expectancy and life expectancy, whilst making sure that we tackle the health inequalities that unfortunately, certainly within Scotland, are ingrained within our population. Most of those health inequalities determined by socio-economic disadvantage, but not always, because we sometimes forget about some of the personal characteristics that people carry that lead to health inequalities as well, whether that be gender, whether that be the racial background, whether that be some of the life experience. But health inequalities of all forms we need to make sure that we tackle, because that's a social injustice that for me is unacceptable in a modern society. The third challenge, in the context of modern healthcare, how do we create a sustainable health and care system in the face of that relentless increase both in the intensity and complexity of clinical practice, but also a very changing demographic need that's in the background as well? And making sure that we have preserved, certainly in Scotland, universal healthcare that's accessible no matter where your background is something which for me is an absolute critical necessity for our population. Fourth population health challenge is the planetary health crisis and the impact that that has on human health. Because whether we like it or not, the planetary health crisis is very real and making changes to human health around about us even as we speak. And even in a country like Scotland, we've already started to see different patterns of disease as a consequence of climate change. And I'll say a little bit more about that in more detail later. But unless we address that planetary health crisis, the human public health crisis that arises from that is something which we are going to find difficult to face in the future. 4 population health challenges. Now, the important thing about these 4 challenges is they are not separate challenges. They are not silos. And unless we take action on planetary health, it's those who already suffer the greatest inequalities that are going to suffer further inequalities. And the evidence suggests that, again, it's those most disadvantaged in society who are likely to experience greatest challenges from infectious disease. And of course, all of that makes the likelihood of a sustainable healthcare system even smaller in the future. So we need to take action across, in a balanced way, across all these 4 challenges in order that the health of our population in the future is all that it possibly can be. So this is Scotland, so-called the sick man of Europe. And there's some truth in that. Because actually, when you look historically at the outcomes that our population has enjoyed compared to other countries, across many different factors, they are poorer than comparable Western countries. Why is that? The reasons are complex. Partly it's related to genetics, partly it's socio-economic, partly it's ingrained behaviours which need addressed. But over recent times, probably starting about 2012, we started to see something strange happening with both our life expectancy and healthy life expectancy curves. And for some of our communities, first of all, we started to see a slowdown in the rate of improvement that we saw in both healthy life expectancy and life expectancy, and then a reversal in some communities. For the first time in decades, there was something happening here, there's something at play that was reducing the health of our population. People were dying earlier, and people were living longer in ill health as well. You can track back the origins of this to the banking crisis of 2008 and some of the choices that were made at that point in time in the UK and in many Western countries around about austerity and how they tackled that banking crisis. And unfortunately, what we began to see is that, again, those who were most disadvantaged in society had suffered the greatest impacts of some of those decisions. So whether that be about some of the diseases of despair, of suicide, of drug use, of alcohol abuse, or whether it be about sometimes access to services, there was an influence in those life expectancy. And it's important to understand that background if we're going to try to rectify how we improve that for the future. Because the future, when you look at the modelling studies that we have addressed in Scotland, what we begin to see is that through demographic change alone over the next 20 years up to 2043, we'll see a burden of disease across our society increase by 21%. And most of that will be felt across cardiovascular disease, across cancers, and across neurological conditions such as dementia as well. That 21% increase in the burden of disease is not manageable by traditional healthcare alone. And if we meet that unchallenged, our systems will fail. We will not be able to provide the care on a universal basis that we would want to provide. We need to start doing something very, very differently. What do we know about the health of our nation just now? So this is the inequality gap that you see across the Scottish population. In life expectancy, there's an inequality gap of 14 years for men and 11 years for women. But if you look at healthy life expectancy, it's 26 years for men and 25 years for women. So people are becoming ill at a younger age, living with that chronic disease for longer. Now, the risks with that is that as they live with that chronic disease, they are less able to contribute economically to society. They are less likely to be able to remain in meaningful employment. They may become economically inactive. But also they are less likely to be able to contribute as much as they would like to their families and to their communities as well. So the net loss to society is huge as a result of that. So prevention is not simply about making sure that we get to a better place with addressing the sustainability of our healthcare services. There's a net benefit for the whole of society as well. The chart that you see on the screen, the red proportion there is the proportion which of disability adjusted life years lost as a result of socio-economic deprivation alone. And you can see in Scotland that the main areas that that's lost in across ischemic heart disease, drug use, lung cancer, and chronic respiratory conditions like COPD. These are the areas where we know there is so much that we can do to try to prevent ill health. And we need to make sure that we're taking a better approach to doing that. And simple, we need to get out of the repair shop mentality that has existed across healthcare and the NHS now for some decades and get much more strongly into prevention-based approaches. And Rod used this figure earlier on in his presentation, but OECD suggests that 20% of all healthcare is of no value to the people who are receiving it. It doesn't materially improve their health. The waste in terms of finance, in terms of time, in terms of burden to people, in terms of resource, in terms of natural resource that's tied up in that 20% is huge. And we need to make sure that if we're going to have sustainable systems of care in the future, that we're addressing that. Now, that fourth element of the population health challenges that I spoke about, planetary health, is something which I've become incredibly interested in over the last 5 years. It's the recognition that actually we are in a changing world. It is volatile, it is uncertain, but there are things that we can do to reduce that level of uncertainty for the future. And we think about the planetary crisis, it's not just about greenhouse emissions, but also about the loss of biodiversity and of air pollution that many people suffer across the world here. But in this infographic here, you can see the range of impacts that climate change begins to have on human health. It's not just about the changing vectors that we see and how the disease that they bear can infect a population. In Scotland, over recent times, we've had a very first case of tick-borne encephalitis, a really unusual occurrence in the UK, but certainly the first that we've had in Scotland. And already we're starting to see through southern Europe, and if I might say in Paris, changing patterns of vectors that we would normally associate with a more tropical climate. And that is likely to change. But food insecurity, water insecurity, extreme weather events, the impacts of those, climate migration, all of these things will impact on our populations and the health that they have as well. Preparing for that is something which our health systems need to do for the future. Ensuring that we have more resilient infrastructure for those extreme weather events in the future is part of that. But recognising that healthcare alone contributes somewhere between 4 and 5% of all greenhouse emissions globally, and searching for the more green, sustainable ways of delivering care for the future has to be part of our overall goal for care as well. Now, I've not mentioned this one. I've talked about 4 population health challenges, but I feel as though I need to mention this. And I suspect it's going to be not the last time we hear about it over these next few days. But I am concerned about what I've called the creeping industrialisation of care, the emergence of a very transactional approach to the way that care is created with our patients. And I use that term with some thought. I've often thought that actually the term care provider is something which is difficult. It suggests a very parental approach. But actually when we create care together with patients, it takes it to a completely different place. And that creation of care can only happen if we begin to see the people that we are trying to create care with in glorious high definition, with unhurried conversations. And anyone who's working in the UK healthcare system just now knows the degree of challenge that creates to do that. But we must find better ways of supporting clinicians to be able to have those type of conversations in an unhurried way, so that we can give care that fits properly to what people's preferences are. I promise it's not all doom and gloom, because there's a solution. And Rod's already started to speak about it. I really firmly believe, I truly am committed, and I'm optimistic that in Scotland we've got a way of working that actually starts to counter some of those challenges that we face. And we've spoken about realistic medicine today, and realistic medicine is probably the greatest thing that's ever happened to me in my career. It began out of a number of conversations 10 years ago when I was Deputy Chief Medical Officer, when a group of us who were like-minded got together and tried to put down in paper some of the things which we felt were dissonant about the way that we provided care. And we listened to people, and we sought inspiration from people like Victor, from Iona, from others, and said, well, what if we started a conversation with the profession that challenged the status quo, that said there might be another way of doing things? And it took extreme courage for my predecessor, Catherine Calderwood, to put this together and encapsulate it in our first annual report as CMO. But I think it's an important conversation. It's important because medicine had started to overreach itself. Over diagnosis, over treatment, over investigation, were words which we uttered infrequently at that point in time, but over the last 10 years, we've seen the situation only become worse. Now is the time that we need to tackle that and make sure that we are taking a much more measured, co-created approach with our patients. And realistic medicine offers a way of doing that. Alongside that, we need to create a sustainable model of care, and a care where we provide that higher value care, where we identify the waste within the system, where we make sure that that lower value care that doesn't add value, that doesn't make an impact for people, doesn't fit in line with their preferences and is often harmful, that we're identifying that and removing that from our practice as well. And all these elements of realistic medicine work together to try to provide care in a slightly different way. Now, Rod showed this infographic earlier on, and I think it's important to understand the origins of this. So when David Sackett began to talk originally about evidence-based medicine, there's a wonderful editorial that says what evidence-based medicine is and what it isn't, and he very, very clearly describes in that article that actually for true evidence-based medicine to be practiced, there had to be three elements. And it wasn't just about the research evidence, but actually it was about how that research evidence was taken in the context of a good conversation with people to determine actually what their goals were from their care. Knowing them, applying what we've called here practitioner wisdom, to be able to take that evidence and to use it in a constructive way. And when you start to understand the research world and actually the exclusion criteria that exists, what you start to see is that actually most of the evidence that we base those guidelines on anyway bears no recognition to the people that we see in our surgeries and our consulting rooms on a day-to-day basis. And in fact, a quarter of trials on condition-specific exclude 90% of patients or more with that condition. This was a review of almost 20,000 trials on PubMed, led by Bruce Guthrie in Scotland. And you can see now that actually the evidence that we think we have for a particular approach, well, we need to use our critical faculties to understand that actually it may not apply to the individual that is in front of us. So guidelines are fantastic when taken in that context and when used properly with a bit of practitioner wisdom, but also very, very clearly focused on what matters to the person in front of us. And we've got a responsibility in this as well, haven't we? Because actually, other trials have shown us that how balanced is the conversations that we have with patients. Well, this is cancer care. You would think that this is an area where we need to make sure that the quality of the conversations is as good as it possibly can be. And yet, 24% of the consultation time is actually taken up by patients, and the majority of it is taken up by the practitioners speaking. So changing that balance and listening properly to patients has to be a part of that. And shared decision-making lies at the heart of the realistic medicine approach, which takes that. This is results in Scotland from Citizens Panel 14. So this is a regular consultation that we have with a sample group, random sample group of over 1,000 patients in Scotland. And the return rate in this particular sample was just over 50%. But really asking questions about realistic medicine and shared decision-making. Now, this gives me some encouragement that the approach we've been taking over the last 10 years is beginning to have an impact and have an effect. When I see that actually over 80% of patients say that they're treated with compassion and understanding, and that they were listened to, and the healthcare professional who saw them understood what mattered to them, that shows to me real progress from where our starting point was. Of course, there's still more that we can do. And how we involve the people that matter to them better in the conversations is something which we're starting to look at too. But this certainly gives me some cause for encouragement as to the journey that we've been on. And you can see how strongly supported shared decision-making is in patients' preferences in this panel. So how have we gone about that? I think this was probably one of the most important starting points. the adoption of the brand questions that Rod spoke about earlier. So what are the benefits of my treatment? What are the risks of my treatment? Are there any alternatives, treatments that I can try? And what if I do nothing? And now when you get an appointment for any clinic in NHS Scotland or any specialty, as part of that, a leaflet detailing and these questions, supporting patients, empowering patients to ask these questions during the consultation is given at the same time, just to try to make sure that these conversations, even if not elicited or initiated by whichever healthcare professional you are seeing, is that patients feel empowered to be able to begin to ask those as well. At the same time as that, we've changed our training for clinicians across the country, and this is not just about medics, this is about all professions. You see it through very strongly through the undergraduate programmes that Rod has already spoken about, but also in continuing professional development and postgraduate training as well. These are some of the modules that are available from our national education authority, the NHS Education for Scotland, and they include a variety of animations explaining some of the terms that are used in realistic medicine, some actual training modules on shared decision making, on managing risk, and an introduction to value-based health and care, and sways, which are information leaflets, really pretty ones, which just again give more information about a variety of different things. These are all there to try to change the culture of learning that we have across our clinical workforce, and clinicians across Scotland are expected to undertake these on a regular basis. We've also been doing a collection. Rod mentioned the realistic medicine teams. These are our chapters that we have across the country, and they are in each one of our health boards and lead the work in realistic medicine within those local areas, exemplifying the type of practice that we would want to try to see. We recently published a casebook earlier this year looking at these particular areas of realistic medicine: personalised care, shared decision making, how we go about reducing harm and waste, and innovations and improvement, and really using that as a way of trying to seed good practice across the country. We're about to take that into further work with our medical directors and nurse directors across the country to make sure that those particularly fine examples of the realistic medicine approach we're now beginning to scale up across the country as well for patients. And it's worth a look through if you get the chance on that QR code. We're constantly checking in with our workforce as well, just to make sure that we have a sense of where they are in their understanding of realistic medicine. The most recent survey in 2025 certainly suggests, albeit on a relatively sparse return rate, that we're getting there in terms of making sure that we're embedding the principles of realistic medicine right across the rather sizable workforce in health and social care in Scotland. But we're also working with partners across the globe as well, just to make sure that we're maximising the opportunities that we have to try and do more work. Medicines has become an area for all of us where we recognise the potential dangers of particularly polypharmacy associated with multimorbidity. And across Europe, 8.6 million admissions every year as a result of adverse drug events, many of them preventable, particularly in the over age 65 age group. So in Scotland, we've been using a project called iSympathy, working in partnership with the Republic of Ireland and with Northern Ireland to develop a 7 steps approach to appropriate polypharmacy and making sure that we're reducing the treatment burden and the potential risk and harm that patients are exposed to with multiple medications. Our updated draft guidance is out to consultation just now. You can see a link to it there. It's an extensive document, but when it's published, it'll be published in app form so that it's interactive and so that clinicians can use it in a ready, accessible way, just to make sure that we get the biggest benefit from it as a decision support tool in the conversations that we're having. I've also become incredibly interested in continuity of care. Now, when I came into practice, continuity of care was the bedrock of general practice. It was the thing that made general practice tick. And it was probably, for me, the reason I came into general practice. That longitudinal relational care where you got to know people and their families and you provided care that mattered to them instinctively because you knew the narrative, the biography, alongside the biology you were facing. But we've lost that. And yet the evidence tells us that continuity of care is better, it gives better outcomes. It ensures that people go into hospital less, and it ensures that we've got far less treatment regret as well. So somewhere along the way, the system that we've created, the pressures within that system, have allowed us to lose actually one of the jewels in the crown of the NHS, which is that continuity of care. And so I commissioned a piece of research led by a former chair of the Royal College of GPs in Scotland, Miles Mack, where they examined that evidence base for continuity of care, not just in primary care, but across secondary and hospital-based care as well, to look to see how we could try and re-establish the best of it. Now, it's difficult to do that in the context of where we are just now, but continuity of care has to be our goal as part of any future care model. The preservation of continuity of care, I think, lies at the heart of a sustainable health and care system for the future. And I don't just limit that to primary care. I think that extends to secondary care as well. In Scotland, we produced this climate emergency sustainability strategy for healthcare. Now, this is not just about the way that we procure or build hospitals. This is about how we provide care as well. There's a full section in this which is about the type of care that we deliver. For instance, desflurane is an anaesthetic agent with a global warming potential 2,500 times greater than carbon dioxide, and yet it was still used extensively across our hospitals in Scotland. One of the advantages of having a national healthcare system such as we have in the NHS is we can take a decision simply to stop procuring desflurane. And that's what we've done. We were the first country, and certainly in Europe, to stop using desflurane, as there are many more suitable alternatives that we can use in its place. Also looking and examining the way that we provide care through metered dose inhalers. And here's where the double win comes in, because actually when you look at asthma care in Scotland and the provision of particularly short-acting beta agonist inhalers, we were completely out of kilter, off balance, benchmarked against other European countries. And so the quality of the care was not only suboptimal, but actually the impacts on the environment were too. So making changes in the way that, again, our drug formularies are written to make sure that it's more difficult simply to use short-acting beta agonists alone, to make sure that we've got much more environmentally friendly forms of metered dose inhalers or inhaled therapies have made a substantial difference now in terms of what our greenhouse emissions are and our carbon footprint is in care as well. And it's not just about removing things, it's actually about looking more constructively at the way that we provide care as well. So we know that there's a strong evidence base for green space in terms of how it improves health. It improves not only physical health but mental health. There's even emerging evidence that suggests, exposed to it at a young age, it improves cognitive abilities in children as well. Maximising the use of a green space then becomes something which is a beneficial target for us as well, using different techniques and really a different concept of care. Not just about physical activity, but actually just about being outdoors as well. So whether that be about encouraging physical activity in that space or education in that space, all of that begins to improve our health as well. And this is ultimately led to the population of Scotland's Population Health Framework, published earlier on this year, where we're trying to create a whole shift in culture away from that repair shop mentality, but into a much more strong preventative base, embedding an approach to prevention, not just across healthcare systems, recognising the important but relatively small contribution they have to prevention, but across all public sector organisations. In fact, it's an all society response. With embedding that approach in those organisations and tackling obesity as the two priorities identified within that framework. And I think that this is possibly the most optimistic part of the realistic medicine story, because we know the value of using a resource in this space becomes much more important. It's not to belittle what we provide in healthcare, but unless we do this, we'll not have a sustainable system to provide that healthcare in the future. And we know from the WHO these are the areas where the most cost-effective investments can be made in the future as we tackle that prevention agenda. But as we do that, we've got to make sure that we leave no one behind. And one of the hidden forms of inequalities that I think we often see in society that we need to do more of is the inequalities that older people suffer as well. And actually flipping some of this on its head, recognising that older people are real assets in our society, and preserving their health for as long as possible is beneficial to society, has to be an equal goal for us. And in fact, we know that older people are more likely to volunteer within their communities, and more likely to have caring contributions, and actually have quite a substantial spending capability within the economy as well. Maximising older people's health and prolonging good health and independence has to be a part of our goal. So when we talk about prevention and we talk about embedding it across organisations, it's all about how we make sure that we're giving older people the opportunity to retain that good health as possible. And sometimes that can be about leisure trusts, such as this one in Angus, just having exercise classes, mobility classes for older people, bringing people together for conversations, connecting them. Or it can be using the creative arts in a completely different way. And in Scotland in 2024, we had the first national mobilisation of the healing arts on a national basis anywhere in the world. 376 events across a week during the Edinburgh Festival, where 11,000 people attended a variety of different classes to try to improve their health. The untapped potential of leisure trusts, of community projects, of creative organisations to improve health across our population is something we need to get better at using. And maybe if we start to think about care in a slightly different way, it allows us to use them and fund them properly in a slightly different way as well. And if we stop thinking about care as that top-down parental approach, and think about care instead as something that we do to maintain, to improve, to repair the world that we exist in so that we can live as best as we can, and that we've all got a responsibility and agency in that space for ourselves as well, then we can begin to see how simple skills like cooking, like creating, like walking, can all contribute overall to that concept of care and health and well-being that we need to promote across our society. So finally, enabling careful and kind care is something which is really important for us in Scotland. The 6 principles which are described in this semi-wheel here are, for me, the secret of how we begin to get there. And it is that understanding that when people come to see us, they come to see us often at the most vulnerable moment of their lives. And yet, sometimes we put a power gradient in the way that makes it difficult for them to connect to us. So ensuring that we do all that we can to allow our workforce and our population to connect with each other has to be at the core of how we design healthcare for the future. And these 6 principles, I think, take us towards that. So connecting with people, connecting with our communities, connecting with the place where we live and the planet that we reside in, and connecting with our purpose, for me, is the essence of what we're trying to achieve with realistic medicine in Scotland. The power of connection is overwhelming. I'll leave you just with this last thought from former President Roosevelt. And if you would ever like to get in contact with me, you can find me here. Thank you.